بسم الله الرحمن الرحيم. السلام عليكم. معكم دكتور محمد ضفع الله، اختصاص الباطنية والغدد الصماء. الليلة إن شاء الله حيكون عندنا كيس جديدة، وإن شاء الله الناس كلها تستفيد منها. The chief complaint is extreme fatigue, history of presenting illness. The patient is a 38-year-old man. He's referred to you from Kasala. He's accompanied by his wife to the outpatient department with complaints of worsening fatigue and weight loss. He says the condition started about 6 months ago with progressive weight loss and anorexia, which he was initially happy about because he was overweight. Anorexia here means loss of appetite. Orexia means appetite, and anorexia means loss of appetite. However, over the past couple of months, he began to suffer from fatigue, which prevented him from going to the market where he works. His wife mentions that the patient passed out or lost consciousness, according to her, out of a few times in the past week. But the patient refused to seek medical attention at the time. He reports a productive cough with mild shortness of breath, a low-grade fever, and occasional night sweats. He denies headache, but he admits to lightheadedness. There's no joint pain or swelling that is noticed, nor does he endorse any skin rash. So in review of systems, he endorses abdominal discomfort, constipation, and muscle weakness. His wife also noticed that the patient's skin complexion or the skin color being darker despite him working indoors. Past medical history is negative for anything that would suggest or help the diagnosis, maybe some minor illnesses, but it's otherwise negative. He's unsure about any vaccination or his vaccination history. His family history is non-contributory to our case. His social history, he works in a crowded indoor market for textiles in Kasala. So he sells textiles and things in Kasala indoors in a crowded market. He's married for 11 years. He has 2 sons and 1 daughter. His home medications, he tried using multiple home remedies, but he did not have any response to these. If it's not written here, so that means it's probably negative that he's not on any long-term medications. Allergies, he's only allergic to dust. On physical examination, his vital signs, blood pressure is 90/55, heart rate is 61, respiratory rate is 24, and his temperature is 37.8. Generally, he has some temporal wasting. There's somewhat of a dark complexion or dark skin color or dark tone. He appears dehydrated. HENT, there's some palpable neck lymph nodes, but none of them are more than 1.5 centimeters. His chest examination shows dullness to percussion and bronchial breath sounds in the right upper lobe area. Otherwise, the lung examination is normal. Cardiovascular system, his apex is in the 5th intercostal space mid-clavicular line. There's a normal S1 and S2 with no murmurs or added sounds heard. Abdominal examination, he has a scaphoid abdomen with decreased skin turgor. That means there's some tenting when you pinch the skin. There's no organomegaly. There's slight tenderness throughout the abdomen, but no rebound. And also there is normal bowel sounds. On extremities, he has generalized wasting with some loss of strength. It's a 4/5 power. He has normal sensation. There's no skin rash or any deformity or any swelling in his extremities. So which of the following is the most likely diagnosis? Take a few minutes or a few moments to go back to the case, reread the case again to come up with the diagnosis from this list. So either A, multiple myeloma, B, Guillain-Barré syndrome, or AIDP, acute inflammatory demyelinating polyradiculopathy. That's AIDP. Or is it C, primary adrenal insufficiency, or D, secondary adrenal insufficiency? Okay, so the patient underwent some laboratory tests that were ordered, and these are the results. His sodium is 128. That's low. Normally, it's about 135 to 145. That's the normal sodium, but his is 128. His potassium is 5.4. Falls in the upper end of the normal range. Some say the upper limit is up to 5.3. So this is probably just slightly elevated or in the upper limit of normal. Chloride is 103. That's pretty much in the normal range. Bicarbonate is 21, slightly low. Normally it's about 24. BUN is 15. This is also normal. Um, and creatinine is 1.1. This can be slightly elevated or it can be normal, depending on the patient's weight and what the previous creatinine is. If we have a previous creatinine, you can compare, but if you don't, you assume that normal creatinine is up to maybe 1, and you also have to take into account the patient's weight. Calcium is normal at 8.9. His WBC count or white blood cell count is elevated at 14,000. Hemoglobin is low at 9 grams per deciliter. And his platelet count is normal at 200,000. So he underwent arterial blood gas and his pH is 7.3. That's slightly low. PCO2 is 37. That's also slightly low. Normally it's about 40. And PO2 is 77. Falls in the lower end of the normal range. Normally it's between 75 to about 100. His ESR or erythrocyte sedimentation rate is elevated at 88 millimeters per minute. So what laboratory tests, what other tests should you order or should be done, and what should be done for this patient? Or how should you treat this patient? Sorry, there's a typographical error here. It's how should you treat this patient? So take a few minutes to think about the answer. Pause the video before proceeding for a better learning experience. Okay, so the patient is admitted to the HDU. It's a high dependency unit for further investigation and evaluation and treatment. He's placed on airborne isolation room for suspicion of active pulmonary tuberculosis. So airborne diseases, you need to place the patient in a separate room. It has to have good ventilation, and everyone who is seeing the patient has to wear what we call an N95 mask. Some of you might have heard of this type of mask. So it isolates about 95% of microbes. And so with airborne diseases, you have to wear a filtration mask, and the patient has to be separate in a well-ventilated room. There's a suspicion here that he has pulmonary tuberculosis. You can go back to the case details to see why they think that he has pulmonary tuberculosis. Some of the clues are that he came from Kasala, which is a high endemic area for tuberculosis. He works in an indoor crowded market. He also has some features, clinical features to suggest tuberculosis. So they ordered some tests based on this thought of this suspicion. So one of them was the chest X-ray, sputum for acid-fast bacilli and tuberculosis culture or Mycobacterium TB culture, and then an HIV serology. You always have to think of HIV in patients who develop pulmonary tuberculosis. And also they ordered serum cortisol and ACTH. Again, go back to the case details to see why they think they want to order these tests, cortisol and ACTH, especially the laboratory values that he has, as well as the vital signs and some of the clinical features that he has. So this is the chest X-ray of a different patient, but the patient's chest X-ray is similar to this young woman's chest X-ray. This is the source. We got it from Radiopedia. It's a good site to review imaging. And so in this chest X-ray here, there is an area of focal consolidation, but there is some thickening of the lung parenchyma, and there's it's a sort of a patchy opacity here. So there's some opacity here, here. So it's widely dispersed, and the normally the minor fissure would be straight ahead, but here it's thickened and it's curved upward. So this suggests that there's some mild, maybe fibrosis in this region or so. So the treatment plan, so they admitted him to the HDU. They have to write a treatment plan after they ordered these tests. So they placed an intravenous line. That's the first thing you want to do, to give IV fluids and medications and etc. He was given 2 liters of 0.9 saline or normal saline intravenously. After collection of samples for acid-fast bacilli from the sputum and blood for liver function tests, he was started on what we call RIPE therapy plus vitamin B6. So RIPE therapy stands for rifampin, isoniazid, pyrazinamide, and ethambutol. This is somewhat standard therapy for tuberculosis. There are other therapies, but this is usually the standard therapy. So you have to give vitamin B6 to prevent neuropathy with isoniazid, and they give them 50 milligrams every day. The patient should be monitored. His vital signs should be measured at least every 6 hours, probably sooner or probably at a more frequent rate or frequency rather um, than any other time. So he's currently somewhat stable, but his condition can become very critical if he's not monitored and treated properly. You should also monitor urine output to make sure he is putting out urine. So some of the lab test results came back. So his serum cortisol is quite low. It's 2.6 micrograms per deciliter. His ACTH is elevated. And his acid-fast bacilli were seen on Ziehl-Neelsen stain. His LFTs are normal, and his HIV test is negative. So the serum cortisol is quite low here. To make a diagnosis of adrenal insufficiency, you don't need to do an ACTH stimulation test if your serum cortisol is very low at 2.6. And so it should be typically an AM cortisol, but if you get a random cortisol and it's less than 2.6, for most cases, it's pretty much diagnostic almost. If you do an ACTH stimulation test, it might just be redundant and you would get a similar result of a low cortisol. Since normally you give ACTH or cosintropin, which is an analog of ACTH, to the patient intravenously, and then you check the serum cortisol before you give the medication, 30 minutes after you give the medication, and 1 hour after you give the medication. And so normally you should expect an increase in cortisol to the effect of the ACTH stimulation. But if the cortisol does not rise up to a level of about 18 or 20, this probably will lead you to come up with a diagnosis of adrenal insufficiency. But in this case, it's very low, and so this is highly suspicious or highly uh, it is highly suspicious of adrenal insufficiency, and so you probably don't need to redo an ACTH stimulation test. We'll see why his ACTH is elevated and what it means. And so an intervention that was given immediately or that was done immediately is that he was given hydrocortisone 100 milligrams followed by 50 milligrams every 8 hours. And this is to address his very low serum cortisol. And this is probably one of the more important steps to do in these cases. So another question, or that's the previous question rather, which is the following is the most likely diagnosis? And hopefully from what we've seen so far from all of the results, you came up with the correct diagnosis, which is primary adrenal insufficiency. And so this is the normal adrenal gland. It has three zones plus an adrenal medulla. These are the cortex. These are the cortical layers. If you remember from your physiology, the zona glomerulosa produces aldosterone, and the zona fasciculata produces cortisol, and the zona reticularis produces androgenic steroids. The medulla, of course, produces epinephrine and norepinephrine. And so in a normal state, the hypothalamus releases corticotrophin releasing hormone. This stimulates the pituitary gland, the anterior pituitary gland, to be more specific, to release ACTH. And ACTH in turn stimulates the adrenal gland to release cortisol. And you also have aldosterone, but it's independent from this feedback loop here, in which it's more so it has its own feedback loop with the renin-angiotensin system. If you remember from your physiology, the RAA system. And so sometimes if you don't have ACTH stimulation, you can still produce aldosterone, but the cortisol will be affected. And so in primary adrenal insufficiency, and this is the diagnosis here, the problem is in the adrenal gland itself. So the patient doesn't produce cortisol, they don't produce aldosterone also. And so the negative feedback loop here is faulty. And so normally you get a negative feedback to the hypothalamus and then to the pituitary. And when we measure the ACTH, because there is no negative feedback, the ACTH will be remarkably or markedly elevated because it's trying to stimulate the adrenal gland to work, while the adrenal gland is dysfunctional primarily. And so you will find an increase in ACTH. Another thing that we probably noticed in the case is that this patient's complexion has become darker. It's because ACTH is released with melanocyte stimulating hormone, or MSH. And so this hormone stimulates the melanocytes to produce melanin, and so the patients become darker in their skin complexion. The aldosterone system is also affected, as I said, because there's destruction of the adrenal fasciculata layer. And so, glomerulosa layer. And so you don't have enough cortisol, you don't have enough aldosterone, and so you don't get enough sodium reabsorption. The potassium is released into the urine, and that leads to hypernatremia and hyponatremia and hyperkalemia. All right. And so in secondary adrenal insufficiency, the problem is in the pituitary gland. So there's not enough ACTH production, and therefore cortisol is low. However, aldosterone is probably normal, as I've said before. With tertiary adrenal insufficiency, the problem is there's a CRH deficiency. Its features are similar to secondary adrenal insufficiency, where ACTH is low and cortisol is low. So this is the pathophysiology of adrenal crisis. And so normally you have the zona glomerulosa, which produces aldosterone. When it's destroyed, you don't have enough sodium reabsorption, and so the patient becomes hyponatremic. The zona fasciculata is also destroyed, and there's a decrease in production in cortisol, and so there's cortisol deficiency, and it has multiple effects. So the immune system is affected, where there's an increase um, in inflammatory cytokines. There's a sickness type syndrome, so the patient feels sick, and there's fever and fatigue. And so this is due to stimulation of the inflammatory pathway um, due to the cortisol deficiency. Um, and also another effect is that there's not enough production of gluconeogenesis precursors, which is the amino acids and the fatty acids. And so there's decreased gluconeogenesis, and some patients will develop hypoglycemia. Another effect is a vasodilatory effect from the cortisol deficiency and increased capillary permeability. And sometimes that's why the patient develops hyponatremia, excuse me, hypotension, and also the hyponatremia and volume depletion will lead to the hypotension as well. So one of the important things to do for patients who develop primary adrenal insufficiency or any adrenal insufficiency is getting an emergency medical information card. In some areas, it's a bracelet or a necklace. This is to have with the patient at all times, every time, all the time. And so the patient will have this this information card or this alert bracelet for emergency medical services. For example, if the patient is found down, unconscious, they would know that this patient is suffering from this disorder, and they would rapidly administer cortisol that can be life-saving. So the plan has continued. So this patient was given a dose of cortisol. So over the 1 or 3 days following, you can taper down the cortisol or the hydrocortisone to a maintenance dose. And so you give about 15 milligrams of hydrocortisone upon awakening. So once the patient wakes up, don't limit it to a specific time, say, 8 a.m. or 7 a.m. They just take it upon awakening. If they wake up at 10 or 11, they overslept or something, they can still take the medication. So, and then you give them a 5 milligram dose in the PM. You don't have to memorize the dosing. But know that that you need to give them a maintenance dose of steroids. That's the important part. If there is no hydrocortisone in the pharmacy, ما في hydrocortisone, then you can give prednisone 5 milligrams, and this is an equivalent dose to the combined 20 milligrams. So 15 plus 5, that's 20, and the ratio or the bioequivalency is about a 4 to 1. So 1 milligram of prednisone equals about 5 milligrams of hydrocortisone. Normally, we don't give dexamethasone because it's very strong. Dexamethasone is a very potent steroid, so we don't use it for maintenance. We only use it for emergency if we need it. And then you also, because they have a aldosterone deficiency, you also give them mineralocorticoid replacement with fludrocortisone. And you start this after you stop the saline infusion. So you have to educate your patients before they are discharged with very important but simple instructions. Number one is you ask them to eat salt or use salt liberally. So no restriction in salt. يعني ما تقول له قلل من الملح. No, they have to ياكلوا ملح زي ما دايرين. That's important because they have salt loss. Also, you monitor for side effects of the steroids. So if the patient comes in and complains of rounding of the face or fat redistribution, or if the muscle weakness becomes even more severe, especially proximal muscle weakness, if they develop striae in the abdomen, etc. So these are all features of steroid excess, and you have to lower the dose of the glucocorticoid or the cortisol. In cases of illness, so the patients, they do become ill at times, and they even are predisposed to more illnesses. And so these are instructions you give them. So they don't have to rush to the emergency room every single time they become ill. If they become ill with a mild or moderate illness, they can double the dose of the glucocorticoid. So, for example, if the patient is on 15 milligrams hydrocortisone in the morning and 5 in the evening, 5 milligrams, you tell them take 2 tablets or 30 milligrams in the morning and maybe 10 milligrams in the evening as at the times or during the days that they are sick, and then they go back to the normal dosing once they become a little bit better. They don't need to increase the mineralocorticoid, however. The mineralocorticoid, you don't have to increase. So if the patient is unable to keep the medications in the stomach, so they have vomiting. If they have severe vomiting, they take the medicine, it doesn't stay in the stomach for 5 or 10 minutes even. They start to vomit. So what do? This is another thing that they have to have are pre-filled syringes or injections of steroids, either hydrocortisone or dexamethasone. So a strong, potent steroid. You have to have them pre-filled. You don't want to give them the medicine in that unfilled or ask them to not pre-fill it. They have to have the syringes filled. يعني يكون الحقن مليانة دواء تكون جاهزة عشان إذا احتاجوا لها في أي وقت يطعنوها بسرعة. Okay? So they give them intramuscularly and then they go to the emergency room. They have to go to the emergency room. يعني ما ياخذوا الحقنة ويقعدوا في البيت لحد ما يبقوا كويسين. No, ده ما حيبقوا كويسين. You take them immediately to the emergency room after the injection. This is to take them to the emergency room. يعني الدواء ده بياخذوه عشان يقدروا يكونوا يعني well enough إنه يقدروا يمشوا emergency room. So this is just a sort of just a temporary measure. And then they have to follow up in the endocrinology clinic. If, after all of this is done, all of this teaching, you ask them to follow up in the endocrinology clinic for dose tapering and adjustment. And this is the end of our presentation. Hopefully, this was a useful case and a useful session. It is very important to know the features of adrenal insufficiency. It is a very serious disorder when it does occur, but with the right knowledge, you will be able to help treat these patients. One of the things we haven't discussed is the effects of or the cause of the adrenal insufficiency in this patient. And here it's infection. He has tuberculosis, and it's probably been going on for some time. And usually it's probably the most common cause of adrenal insufficiency worldwide. In developed countries or like European, Western countries, some other countries, it's not as common. They usually have the most common cause there is autoimmune destruction. But in most countries, the cause is an infectious cause. HIV is also another cause of adrenal insufficiency. There's multiple causes for adrenal insufficiency. This is probably your homework to learn about the different causes of adrenal insufficiency. Thank you for tuning in.